Hello everyone. Today I'll be talking to you regarding disease of the gallbladder. Okay. So in this I'll be having integrated approach A to Z, and I'll be covering all these subspecialty which are relevant to my talk. So before we really go into the subject of gallbladder, let's learn the basic anatomy and physiology. Without the basic concept you will not understand. So in the anatomy we have a gallbladder, just like a shape of a pear, lovely fruit, and the duct which drains its cystic duct, and the cystic duct comes and it combined with the duct which is coming from the liver, so called common hepatic duct. Okay, common hepatic duct, and once they unite, that is cystic duct combined with the hepatic duct, and that makes the common bile duct, and this common bile duct comes and unites with the pancreatic duct, and finally this duct open into the sphincter of Oddi. There is an ampulla of Vater, and that opens into the sphincter of Oddi. But there is important point to remember. I talked to you that we have a hepatic other, that is we have a pancreatic duct which combined with the common bile duct. But point to be noted that we have a SS3 pancreatic duct that opens separately, that is not uniting with the common bile duct. So I can make you a lovely diagram for you for your easy reference. Here is the bile, here is the gallbladder. This is the cystic duct, and here is the hepatic duct coming. Hepatic duct, cystic duct, and they make common bile duct, and this common bile duct they come down, it combined with the pancreatic duct. PD is pancreatic duct, CBD is common bile duct, and ultimately it makes a ampulla of Vater. This is ampulla of Vater, and that opened into second part of the duodenum, which is coming like this, and this opening is known as is sphincter of Oddi, sphincter of Oddi. So I hope you could draw the diagram, but what I wanted to say was pancreatic duct, it has a SS3 pancreatic duct also, and that opens separately, not via the into the ampulla of Vater. It has a special meaning. All these I'll be discussing in due course of time. So again, you look into the diagram, and I hope now you can appreciate better common gallstone, cystic duct, hepatic duct, common bile duct, pancreatic duct, ampulla of Vater, and sphincter of Oddi, and SSC duct. After this, we go on to the I must mention you in the anatomy. There's something special. In the gallbladder, we have a Hartmann pouch. It is a outpouching in the wall of gallbladder at the junction of neck and cystic duct. Well, you will not understand unless I show you a diagram. Look into this diagram. Look into this diagram. Again, this is a diagram, lovely photograph of the gallbladder. So here is the fundus of the gallbladder. Fundus of the gallbladder. This is a fundus. Fundus. And this is the body of the gallbladder. Body. body of the gallbladder. And here is the neck. Here is the neck. And there is the Hartmann pouch. This is Hartmann pouch. Hartmann pouch. This one. Right? So it has a special meaning. It is just a out. You can say it's just a pouch. That's why we call it Hartmann pouch. And finally, here is the spiral wall valve is there. Cystic duct has a spiral valve, or lining inside cystic duct is a type of valve, spiral type of valve is there. Okay. So you understood there is something called Hartmann pouch. This you can see very lively in this particular place. If you want the picture again, now you can appreciate much better. Yeah, Hartmann pouch. Right. So we come back to our description. We learned the parts. So we learned about the location, what the Hartmann pouch is. It is just near the cystic duct. Now why it is so special to spend 2 minutes on this point? Because it is a site where gallstone impacts, where the gallstone come and impacts, which lead to mucocele of the gallbladder. Definitely it is lying near the cystic pouch. If a stone comes to that place, it may definitely block the neck of the, it can block cystic duct. And that can lead to formation of the mucocele. About this I'll be talking to you detail it later on. So as of now, there are only one keyword to remember about Hartmann pouch, that is mucocele of the gallbladder can occur by the stone which is there in Hartmann pouch. So keyword Hartmann pouch stone which can lead to mucocele. What the mucocele is, we'll talk later on. So one keyword mucocele. Now we talk about some bit of physiology of gallbladder, without which you will never understand the subject properly. Well, it is true that bile is produced by the liver. This we have read in our physiology of liver. And we also know that ultimately bile canaliculi, they come to bile duct. So and those of you, I have taken a full lecture on this also. And especially you can see in the chapter of primary biliary cirrhosis, where I mentioned detail how the bile is formed and how it moves in the liver and outside the liver. Those of you who have not seen, you can see that lecture. As of now, bile is produced by the liver. Okay, and it is stored in the gallbladder. Point to be noted. So liver is the, you can say, site of formation. Or if I have to give you a day-to-day example, liver is a factory where the things are getting manufactured. Manufacturing unit is liver, and whatever thing have been manufactured in the liver, they go to, like any other ordinary factory also, the content goes to warehouse. Warehouse for any factory is the place, or you can say storehouse, where the things are stored. Okay, manufacturing is very fast. They go to warehouse, store, and from there ultimately they go to the market for the sale. Well, for us, liver is the factory for the formation of the bile, and the storehouse is the gallbladder. Point to be noted. So we understood. Stored in the liver, simple. So now, and ultimately it comes to the duodenum. I told you anatomy. We are having a cystic duct combining with a hepatic duct, and ultimately making common bile duct and coming to second part of duodenum that we have studied. So now let us see when it is leaving the liver manufactured, what is the content. For in the liver, it is 97% is water. That means is mainly water, 97%. But what are the other components that we have? Bile salt, which include cholic acid and chenodeoxycholic acid, deoxycholic acid and lithocholic acid, and these are the primary bile acid, and these are the secondary bile acid. About this also I have discussed in great detail when I discuss about the liver disease in pregnancy. There is a so-called cholestatic jaundice of liver. I have discussed in great detail. All of you must have seen the lecture, or those who have not seen, please, for more biochemistry and physiology of bile salt, please see that lecture. So I am not going to repeat again. So they contain primary and secondary bile salt. They also contain phospholipid, cholesterol, and little bit of bilirubin also. Okay, so primarily is water, but after that bile salt, phospholipid, cholesterol, and bilirubin, bile salt, cholesterol, and phospholipid. They are the four things which are there, and they constitute about only 3%. So the carry home message is, the keyword to remember is BB, CP, bile salt, bilirubin, cholesterol, and phospholipids. Right? Now, how much bile is made by the liver? It is around 40 ml per hour. So, in 1 hour, it is about 40 ml. So, roughly, if I have to calculate for 24 hours, multiply by 40 ml, around 1 liter, around 960 ml or 1 liter is made in the liver. It's a huge amount, 1 liter, point to be noted. And ultimately, it comes. But why I am discussing this point? Now comes the most important line. Remember, they contain lot of bile salt, which are very, very important for the fat digestion. And all these, one liter of the liquid liver, which is making the fluid, ultimately which contain bile salt. 95% of bile salt are reabsorbed in the terminal ileum via enterohepatic circulation. What I mean to say, it comes to the second part of duodenum, bile, second part of duodenum, and ultimately it goes to terminal ileum. In the terminal ileum, it is reabsorbed, and again come back to the liver. This is what is so called enterohepatic circulation. Bile salts 95% are reabsorbed. Okay, enterohepatic circulation. So the key word to be remembered are 40 ml per hour and enterohepatic circulation, by which 95% of the bile salt are reabsorbed. There are only two keywords, 40 ml and enterohepatic circulation for the bile salt reabsorption. Every line has a special meaning which we'll be using when we go for the clinical applied. Now, 40 ml of the liquid from the liver, it has come to the gallbladder. Now, what is the function of gallbladder? One thing is reservoir of the bile, that we understood. Ultimately, they come. Why this is needed? Again, has a applied. Now, what happens during fasting? That means you can say early morning or late night when the person is fasting. Bile is getting produced from the liver 40 ml or 40 ml per 40 ml per okay, being produced 40 ml per hour. So during the fasting stage, this sphincter of Oddi, this remain closed. It remain closed. So that's why this bile cannot come to the intestine. Okay. So now it will be diverted toward the gallbladder. So it will come to the gallbladder. So in the fasting stage, there is resistance to flow through the sphincter of Oddi. Well, if I have to give you even a better example, we studied that in the esophagus. In the esophagus, we have a sphincter, we have a lower esophageal sphincter, which remain closed during when the person is not eating. Similarly, this sphincter of Oddi, it tend to remain by and large closed when the person is in the fasting state, right? So it remain closed. So now bile is diverted into the gallbladder. Understood? So that's why bile is the storage house, right? It means what? Come the gold medal question from radiology. So suppose you want to do the ultrasound for anything to look for the gallbladder. What you ask, the clinical applied, the ultrasound of the gallbladder should be done in the fasting stage. In the fasting stage, in that time, the gallbladder is fully distended, right? Always remember this, the golden line to remember. You have to tell the patient that you have to go empty stomach. Not even you don't even have to take a cup of coffee or tea also. No, it should be empty stomach. So with the result, the gallbladder will be fully distended and it will be good for ultrasonographer to look into the gallbladder. This is the clinical applied. But once the patient has taken the meals, then this sphincter of Oddi, it opens. It opens, that even that time the gallbladder also contracts and the whole content of gallbladder now enters into second part of duodenum. Okay, so point to be noted is the fasting, the sphincter closed, gallbladder distended in the after eating, after feeding, resistance to the sphincter Oddi is reduced and gallbladder contact and bile enter the duodenum. We are clear about? Okay. But is it complete? No, but why? How come gallbladder contact after meals? There has to be impulse? Yes. Now come the point that this motor response of gallbladder is due to cholecystokinin. The cholecystokinin which come and contract the gallbladder, and that's why the gallbladder empties. So friends, what you have to remember is cholecystokinin and after feeding, the two keywords. So what I have discussed so far in these two slides. Point number one, gallbladder, it is storage site. Point number two, it is distended in the fasting stage. Third, it get contracted after eating, after meals. Fourth, and this contraction is done by the cholecystokinin. Four keywords to remember in these two slides, right? So this was the one function, and ultimately gallbladder has so many things. Bile salt is the most important thing which is involved in the digestion of the fat. Done. Second function, there is one more function of the gallbladder. Second function, Well, a huge, about 1 liter of the of the content is made, bile is made by the liver. It's a huge amount. But once it comes to the gallbladder, it lead to causes concentration of the bile. Concentration of the bile. How can? And remember, 97% is the water. So it will absorb water, sodium chloride and bicarbonate. Okay. So it will try to absorb water. With the result, what will happen? With the result, the whatever bile is made, it will be concentrated. So definitely it will become concentrated. Okay. So the bile will be concentrated. How much time? 5 to 10 times. Okay. 5 to 10 times it will be concentrated, or if I say it 10 times, it means 1000 ml was produced by the liver, and ultimately when they come to the gallbladder, they are 10 times. That means that is goes to somewhere around 100 ml of the bile will be produced, all by concentration. So definitely if the water is getting absorbed, sodium chloride getting absorbed, so it will have increased concentration of the other component. What are the other component? Bile salts, bile pigment, cholesterol and the calcium. All these what we discuss, they will increase. Bile salt, bile pigment is bilirubin, and cholesterol, calcium, which were the other component. If again I show you the slide, again I will show like this soil. So this is getting reabsorbed. So definitely these will be increase in concentration, right? So now concentrated bile is there in the gallbladder. So in nutshell, the first function was storage, second is concentrated. We have a third function also. What is that? What is that? Third function. Secretion of mucus. Mucus is secreted. Come back. Gallbladder. It absorbs water and salt. Salt means sodium chloride. But it secretes mucus. The lining of the gallbladder, they secrete mucus, but not very much. Not very much. About 20 ml is produced per day. Not very much. Okay, but it is secreting mucus, although later, very little, but it is important. So now come the applied. What is the applied of this? Again, we read about Hartmann pouch. This was the gallbladder, Hartmann pouch, cystic duct. A stone is very easily made here. The stone is made, it will going to compress the common bile duct, or it is a cystic duct. So what is going to do is this Hartmann pouch stone, it is going to compress the gall cystic duct. The cystic duct will get compressed because stone is there. Complete blockage is there. Complete blockage is there. So it contain little bit of bile, and now mucus is continuously coming for days together. So now this gallbladder will be full of mucus, and that is the basic pathophysiology why mucocele is produced, about which I'll be talking to you later on. But now that's why knowing the importance of Hartmann pouch stone and anatomy, that cystic duct may get compressed and mucus will be secreted by the lining of the gallbladder. So that's the how mucocele is going to get formed. So friends, three functions: storage, concentration, and secretion of the mucus is the third function. And we learned about how mucocele will be made, right? So only keyword and here is two keyword: secretion of the mucus and the mucocele will be formed. With this background, we talk more about the enzymes. What are enzymes which are involved in the gallbladder? We have a somatostatin, we have a cholecystokinin, and we have a secretin. These we have studied earlier also. So they have a multiple functions. When I was regarding somatostatin, I have discussed in great detail when I discuss carcinoid syndrome, etc. So every of these enzymes have many functions. But at the moment I will highlight only which are relevant to my today's talk. Okay. So somatostatin, they are made by the delta cells, note it down. And what they are going to do with the pancreas and the gallbladder in particular, they cause decreased gallbladder contraction. Point to be noted. So the other thing you can skip, we have, okay, at the moment just talk about, they cause decreased gallbladder contraction, and they also reduce pancreatic secretions also. So definitely if I have to draw a diagram for you, so this is the gallbladder, and ultimately this comes down, and this pancreatic, and this opens in the duodenum. So what we learn, what is going to do? It will not let gallbladder contract. The gallbladder will not contract. The bile will stay here only, definitely. Bile will not move. It is also reducing the pancreatic secretions. So what net result will be? Neither secretions are coming from pancreas, neither secretion is coming from the gallbladder. So secretion into the second part of duodenum, that means overall secretion from the pancreas, gallbladder will get reduced in the intestine. So this is the point what you got to remember. I have highlighted. So this is the point that you got to remember in this. Okay, right? So this is the physiology what you got to remember. That's the only thing what physiology you got to remember, what is relevant to my talk. So friends, somatostatin, and the two things what is relevant to my talk is reduce pancreatic secretion and reduce gallbladder contraction. Okay. Second enzyme is cholecystokinin. We have read earlier that is, it is the one which is going to cause gallbladder contraction. We've studied. So it comes from which place? Eye cells of duodenum and jejunum. Somatostatin came from the D cell of the pancreas. This is eye cell of the duodenum and jejunum. Okay. So it causes increased pancreatic secretion. Point to be noted, it has a reverse action of the somatostatin. It causes increased gallbladder contraction, and it is causing increased relaxation of sphincter of Oddi. So by and large, it has got all the reverse action. So again, same diagram. So it is going to cause increased gallbladder contraction. It is causing increased pancreatic secretion, and it is going to cause relaxation of the sphincter of Oddi. Almost reverse action of cholecystokinin. Okay, so again, I am talking about what is relevant to my talk today. There are the three things I am concerned for today's talk. You also note down what is relevant to your talk, what is relevant to our talk of gallbladder. So, cholecystokinase increase pancreatic secretion, increase gallbladder contraction and relaxation of sphincter vodi. We have one more, so-called secretin. It comes from the S cell of the duodenum. And question only for the students. This secretin we have done somewhere, secreting stimulation test. Question only for the student. Write down in which condition we had used secretin. Infusion test. In which disease or which condition we have done this test? Quickly write down the answer. Question only for the students. Well, I'm sure by now you have written the answer. Answer is Zoringer-Ellison syndrome. Okay. So we come back. So what is going to do it? S cell. Again relevant to my talk. Increase pancreatic secretion. Increase bile secretion. Okay. So overall it is going to increase the volume of the bile in total, because it is causing increased pancreatic secretion. And if you recall, when I took a lecture on pancreas, the initial physiology was in pancreas also, in the fasting stage, pancreatic secretion contain mainly chloride. But after feed, after meals, it contain more of bicarbonate, it become alkaline. Why it is so? Previously it was chloride. In the fasting stage, after meals, the pancreatic become alkaline. Why? What is the basic physiology? Because God is the greatest engineer. He has designed our body in a very fantastic way. So what is the read? Why in after meals it is alkaline? Because the content which is coming from the stomach after meal is all acidic. And this alkaline pH is the one which will going to neutralize to this acid to some extent. Otherwise, if the whole acid goes to the intestine, entire intestine will be corroded. Why? Again, God is the greatest engineer. In the stomach, lot of acid is there, but there are lots of preventive method are there by which, despite having large amount of acid in the stomach, no ulcer form. But to prevent the ulcer formation in the entire GIT, small or large intestine, acid is neutralized by the alkaline pH of the pancreatic juice, okay, which come only after meals. Golden line to remember is this. Okay. Of course, all the enzymes, they also work in alkaline pH. That's the additional finding. So relevant to my talk, increase bicarbonate and increase bile acid secretion is occurred by secretin. So in nutshell, so if I have to summarize the thing about the three enzymes, somatostatin reduces gastric acid, gallbladder contraction. It causes contraction of the sphincter of vodi and reduce pancreatic secretion. Reverse are the action of cholecystokinin. It causes gallbladder contraction. It causes increased pancreatic secretion and it relaxes the sphincter of vodi. Secretin, again, it increases the pancreatic juice as well as the bile acid secretion. This is the physiology, basic concept so far. So now you are clear about the anatomy and physiology to a great extent. With this basic concept, now we talk about one of the most important disease and a very frequently asked question in all the exam is the gallstone, or we also call it to be cholelithiasis. So either but most of the time in exam they talk about gallstone, but of course you never know, they may ask cholelithiasis also. So it is the presence of gallstones in the gallbladder. In fact, this point has been covered in this particular gallstone cholelithiasis. Now what happened? What are the important thing which can lead to formation? Again recall, what was there? What was there in the bile? We had a cholesterol, we had a bilirubin, we have a bile salt. Okay? So increased cholesterol predisposed to stones. Increased bilirubin also predisposed to stone, but decrease in bile salt predisposed to, and gallbladder stasis. Gallbladder stasis. That means if the gallbladder is not contracting, that will predispose to stone formation. So now if I talk about this particular word, gallbladder stasis, okay. In the gallbladder stasis, what we discuss, gallbladder contraction is to done by cholecystokinin and it is reduced by somatostatin. So that's why we need cholecystokinin so that gallbladder keep on contracting, and that lead to reduced stone formation, right? In fact, anything stasis, if the stasis occurs and gallbladder is the function of gallbladder is concentrating, more and more concentration means cholesterol content will go high, and that will predispose to stone formation. Okay, all these again I'll be talking in the coming slides, but as of now we learned that increased cholesterol, increased bilirubin also, and decreased bile salt and gallbladder stasis will lead to stone. What are the types of stone? One is cholesterol stones. It is there also. These are radiolucent. Okay, only 10 to 20% are opaque because they may have some calcification. So by and large, radiolucent only 10 to 20% are opaque regarding cholesterol stones. So the cholesterol stone are seen in which type of the patients? Obese patient. Definitely obese patient tend to have high amount of cholesterol also. But rapid reduction of the body weight, that again further predisposed to stone formation. Crohn's disease, advancing age, more the age, more is likely to have cholesterol problem, more likely to have a stone. Estrogen therapy, multiparity, definitely what the classical thing is fat, fertile, female of 40 years. Okay, you can make it a golden line to remember also. Fat, fertile female of 40 years who come with a severe pain, right upper quadrant or right hypochondrium, perhaps you are dealing with gallstones. Golden line to remember. Right upper brown pain, I'll talk later on. So we are getting obese lady, advanced age, multiparity, lady of 40 years are likely to have stone. Pigment stone, they may be black or brown. They are usually radiopaque. They contain calcium bilirubinate. Remember, what I told you, increased cholesterol or increased bilirubin, and they are classically seen in those patients, those who had hemolytic anemia. In hemolytic anemia, there is increased formation of unconjugated bilirubin, and that combined with calcium and they get precipitated. Since it has got calcium, so they are radio opaque. They are radio opaque. Okay. Second, again, pigment is brown color. Black was hemolysis. Brown is they are radiolucent, but they are primarily formed due to infection, right? So that's why they don't have much of the calcium. So that's why they are radiolucent. Now I must clarify. I have used two terms. What is radio opaque, and other is radiolucent. Opaque means if you do X-ray, you can see in X-ray of the abdomen stone. Radiolucent you cannot see. They are transparent. To be you can say that way also. That the two terms should be very, very clear to you: radiolucent and radio opaque. So friends, second was pigment gallstone. Black radio opaque and the brown is radiolucent. Black is due to any cause of chronic hemolytic anemia, and brown is due to infection, especially cholecystitis. So who are the patients where we see the pigment stones? Crohn's disease. Point to be noted, in Crohn's disease both type of stones are common. Chronic hemolysis, the point I mentioned earlier also. Alcoholic cirrhosis can predispose to this problem. Advancing age, biliary infection. This is the one which is going to have brown. This is the one. This is one which is going to have a black. And total parental nutrition that are also can predispose to stone formation. All right. Keyword to remember here are hemolysis, Crohn's disease, biliary infection. They are the three things that you got to remember in this particular slide. Now, why the stone form or the pathophysiology? One is the supersaturation of secreted bile. Can you think of any condition? Well, if the cystic duct is blocked, okay, or the patient remain fasting for many days patient is fasting. There's no food coming to the GIT. No food in GIT, better, and we know the basic physiology. No food in GIT, gallbladder getting distended. Can you think about? Yeah. Total parental nutrition. Patient is giving intravenous things are given. There's nothing in GIT is coming. This is how TPN can predispose to the formation of stone. And otherwise, anything, maybe cystic duct blockage also can produce same supersaturated. Supersaturation, concentration of the bile, same thing. Crystal nucleation, most of the time there is some nucleus there, and crystal formation occurs around that. What we call as we have a focus. Let's we have got any focus, nidus, what we call as nidus. If nidus is there, then formation of stone around this become very fast. That makes a stone formation. So nidus formation is essential. And finally, gallbladder dysmotility, gallbladder is not contracting. Ultimately, what we can say, this the gallbladder, either it is blocked or it is not contracting or we have a nidus. So three things. Blocked will lead to increased concentration. This is how the gallstones are likely to be made. Of course, there are so many predisposing conditions like hemolytic or any infection, they all predispose or they make a nidus for the stone formation. So I hope you are clear about the pathophysiology of gallstones. Risk factor, obesity, BMI more than 30, rapid weight loss, multiparity, female, and chronic hemolytic anemia. These are the important which also are covered by the fat fertile female of 40 years. Is what is standard thing, the golden line to remember which I mentioned, same thing. The predisposing factor are these. After this, now we come to the clinical side, how the patient is going to come to us. Most of the time, the gallstone, they have no problem. They're totally asymptomatic. And most of the time, they are diagnosed incidentally. Incidentally means you ask the patient to get ultrasound abdomen for any other reason. And when the ultrasound is being done, and he says, oh, gallstones are there. But patient has never any symptom, so we diagnose it incidentally. Most common is asymptomatic. Otherwise, the most common other than asymptomatic, biliary colic, so-called gallbladder pain is severe pain. Okay. Especially when the gallbladder cystic duct get blocked or maybe common bile duct get blocked. When these or the common bile duct get blocked, hepatic duct, common bile duct, cystic duct, hepatic duct. So either the common bile duct is blocked or cystic duct get blocked. So definitely the pressure from behind will be there and that will lead to severe pain, right upper abdomen pain, right? And one of the classical thing is the pain radiates to the shoulder. Point to be noted, in the pancreatitis, the pain was in pancreatitis, pain radiated to back. But in gallbladder, pain is referred to the shoulder. This is a very, very important clue that the patient has gallbladder pain. So friends, here the two keywords are pain and shoulder. That's all. Pain abdomen or right hypochondrium and the shoulder pain are the two things that you have to remember in this particular slide. Associated feature are nausea, vomiting, referred pain I told you. In the shoulder, nausea, vomiting can happen in is a non-specific. You don't have to worry about this thing. But in the exam, Murphy's sign is important. Okay, Murphy's sign is important, and what they do, I'll show you video also just now. We ask the patient to, this the patient, here is the patient, okay, and here is the coastal margin, this is the right hypochondrium, and we palpate. And we ask the patient to take a deep breath. As he will take a deep breath, this gallbladder will move down. And usually in gallbladder cholecystitis is there. The gallbladder is inflamed, and when the inflamed gallbladder, let's say inflamed gallbladder come and touches the hand, and that suddenly patient will jump with pain. There is an inspiratory arrest, so-called Murphy's sign. It is a there is inspiratory arrest when the inflamed gallbladder comes in contact with the examiner hand. We call as Murphy's sign is positive. Okay, but it is a sign of acute cholecystitis, which is often there, often there with gallstone. So I like to show you a video.
Murphy's sign. Ask the patient to exhale while palpating the gallbladder area medial to the midclavicular line. Now instruct the patient to take a deep breath so the gallbladder is pushed down and against the examiner's fingertips as the lungs expand. If cholecystitis is present, the patient will experience a sharp and sudden pain, causing them to abruptly cease inhalation. This reaction is known as a positive Murphy's sign.
So I hope you could see Murphy's sign. There was sudden arrest. You can see the patient jumping with the pain also. Another important sign is Boas sign. There is an increased hyperesthesia, so-called increased or altered sensitivity on touch. Below the right scapula in acute cholecystitis like this. You can see the back below the right scapula. If you touch it, it is hyper sensitive. That means the patient will have increased touch feeling as compared to the other side. Boas sign. But Murphy's sign is much more clinically important as compared to Boas sign. In fact, good olden days, about 30 years back or 40 years back, when even the ultrasound was not there. And I told you X-ray abdomen was non-specific, hardly 10 or 15% of the Reka gallstone were radio opaque, are radio opaque to be more precise. But there was no way to diagnose gallstone. The good old clinician, so technique of examination, which sorry to say is gradually disappearing. We are more and more of so-called machine-based investigation we do. Anyway, the good old days, great clinician, today also the great clinician, they palpate the abdomen and by touch only they can say this is the case of gallbladder Murphy's sign. Is the standard, you can say Murphy's sign. The clinical examination, clinical sign of the olden days is equivalent to the ultrasound of today. Okay, right? So what I want to say, there's nothing to beat the better, good clinical examination. Anyway, we talk about investigation of a case of gallstones. Radiography, only 10% or 10-15 are radio opaque. Okay, and calcium stone can be seen, but porcine gallbladder is seen very well, nicely seen on the plain X-ray of the abdomen. But nowadays it is mentioned in the books, so I have mentioned, but nowadays it is not a very popular investigation. If you have examined the patient and Murphy's sign is positive, you are strongly thinking that I am dealing with ultrasound or gallstone, then you will not go with this investigation. What you will do, you will go with the ultrasound. But what is important for the exam point of view, why I included this point? So now you can see radio opaque shadows. I told you the meaning of opaque means we can see. So you can see stones are there, You can very nicely see so many stones are there in the gallbladder. But what is more important, which is very commonly asked, still the favorite question. Whenever the question on the ultrasound, and we know very well that X-ray is not a very popular investigation, but in the exam, they will talk about Mercedes-Benz sign, so-called Siegel's sign. What is that? When you are doing an X-ray and you can see a like you can see like this. This is the popular Mercedes-Benz car, okay, and you can see similar type of shadow here, maybe in CT also, maybe X-ray also. This is the what you are seeing here, okay. What you are seeing here is like this, so-called Mercedes-Benz sign, like this only. But for exam point of view, this is a favorite question of the examiner. This we can see in X-ray, maybe CT also we can see this Mercedes-Benz sign, okay. Yeah. So why this happen? Because they may contain air or gas. Or center of the gallstone may contain some air, and that gives you a opaque shadow, so-called Mercedes-Benz sign. So for exam point of view, we talk about X-ray, but for all practical purposes, Murphy's sign positive, then the next line of management is not X-ray, but the ultrasound. The best initial test is ultrasound, okay, and it can pick up as high sensitivity is 98%. Of course, it depends on the who is doing, but by and large we presume that a good and experienced ultrasonologist is doing the ultrasound, and they can pick up 98%. Even cholecystitis can be diagnosed, which is often associated with gallstone, but not always. Let's presume it is there. So cholecystitis we can diagnose by gallbladder wall thickening. Point to be noted. So best initial test is the first, and gallbladder wall thickening is seen in cholecystitis. Gallbladder may be even distended also, and there can be some pericholecystic fluid can be there. If it is leaking, the gallbladder is leaking, there can be some liquid fluid outside the gallbladder also. And even Murphy's sign you can elicit by ultrasound also. You put a probe into the subhypochondrium area. You ask the patient to take a deep breath. He take a deep breath and probe is touching. That means whatever you are doing with the fingers in palpation, same thing can be done by the ultrasound probe also. And you can see the patient is jumping with pain. The point to be noted that even Murphy's sign you can elicit by this, by the probe also, and you can see the gallstone or cholecystitis finding by thickening. I think if you get a chance to actually see the stone on ultrasound, thickening of the gallbladder wall on ultrasound, and the patient jumping with pain by deep inspiration, okay, you being a resident, anyway, if you have a patient like this, don't forget to visit the ultrasound room. Ask the patient to show you stone, thickening of the gallbladder wall, and ask him to elicit Murphy's sign by the probe also. Okay, so this is the keyword. So now you can see because there is a gallbladder stone impacted on the neck, and you can see acute cholecystitis. You can see gallstones. You can see thickened wall of the gallbladder, which indicate cholecystitis, and there is little bit of fluid also, pericholecystic fluid also, which you can see. Now you can see this black fluid is there. So what I wanted you to see same picture. Stones, I again mark it. Stones, thickened gallbladder wall, and these pericholecystic fluid. Classical finding that you should see if when you get a chance, otherwise you have seen the photo, now you will pick up better. So friends, lovely findings, ultrasonography. Bile duct stones, they can be seen by sonography but not as better as we see the stone in the gallbladder. But what we can see, bile duct, common bile duct dilated. That is much easily picked up even by they can even measure the size of common bile duct also. Okay, stone may or may not be picked up by the ultrasound, but bile duct dilation again indicate perhaps we are dealing with a stone. Well, in such cases, if we can go for ERCP or MRCP to look for the stone, and but for cholecystitis, remember, not for the stone. For cholecystitis, HIDA scan is a very good test, a very sensitive test, but provided it is only for cholecystitis. So friends, what we learned in investigation is in the X-ray, only 10% are radio opaque and Mercedes-Benz sign. 2 question from X-ray. After that, ultrasound is the best initial test. We can see ultrasound stone number 1, 98%. Thickening of the gallbladder wall which indicate cholecystitis, and we can also see the some fluid around the gallbladder. Then of course books do mention about CT also, CT scan abdomen also, but MRCP or ERCP are more yielding as far as gallstone is concerned. And for cholecystitis we do HIDA scan. What are the complications of a case of gallstone? Well, they may be silent stone. Silent stone means patient has no pain. In fact, it's the most common presentation. So it is the effect, not a complication, right? And it's the incidental finding. It can lead to acute cholecystitis, and it is due to this Murphy's sign is positive. It can be even chronic cholecystitis, mucocele formation. I discussed the basic pathophysiology because gallbladder secrete large amount of mucus, and if the duct is blocked, large amount of mucus will lead to mucocele. I'll talk more about this also. Empyema, sometimes even the mucus gland get infected with the bacteria, then mucus will get converted to pus, what we call as empyema. It can perforate. After all, gallbladder is like a balloon. If the duct is blocked and mucus is getting secreted, the gallbladder become big. Ultimately it can perforate also, and sometimes torsion may occur, and that can lead to gangrene due to torsion. The gallbladder get twisted, and carcinoma, about which I'll be talking in the next lecture. What about obstructive jaundice? Definitely gallstone has blocking the gallstone, the common bile duct. It has blocked common bile duct, block it lead to type of obstructive jaundice, and you get what? You get fluctuating jaundice. Fluctuating jaundice level increase, decrease, increase, decrease, increase. The level of bilirubin will fluctuate. Why? It get blocked, secretion cannot come down, whole bile is backlogged, jaundice increases. but due to pressure of the liquid or the bile, the stone may get shifted from its position. During shifting, the blocked bile may come down. The jaundice will come down. So fluctuating jaundice you get in these cases. Cholangitis, there may be infection or inflammation of the common bile duct, and even it can lead to acute pancreatitis. Remember, the two important causes of acute pancreatitis, one is the alcohol and the other is the gallbladder stones. And in the intestine, it can even lead to gallstone ileus, about which I am going to talk soon. So friend, out of these, important thing that you got to remember are acute cholecystitis, obstructive jaundice, acute pancreatitis. These are the three important things you have to remember in this particular slide, right? Now, about something unique which 99.9% students are not aware, and these are the rank number 1 getting questions. One is the Bowert syndrome. It causes gastric outlet obstruction. Keyword to remember. Right? What and how? What happened? There is a large gall bladder stone, and it goes through a bilioduodenal fistula. That means a fistula has formed between the gallbladder and the duodenum, and this stone will go into the duodenum and will cause duodenal obstruction. Okay, let me show you a lovely picture, then you will understand better. So friends, here is the gallbladder. Here is a big stone in the gallbladder, and this is the duodenum, and a fistula has made, and this will enter the duodenum, and that can block the duodenum. It's a huge stone. It is just like this, the hill. It's a big hill is there, and here's a road going on, hill, and a stone falls on the road. It's very common to happen in the hilly area like Himalayas. Like a stone has fallen on the road, and now road is blocked, right? So friends, similarly, we are getting a stone which is entering into the duodenum via bilioduodenal fistula. Okay, so that will go and cause duodenal obstruction. So definitely surgical treatment is needed. So what you have to remember is, in Bowert syndrome, duodenal obstruction, this is the only keyword. Bilioduodenal fistula, and there is obstruction to the duodenum, and of course you need a surgical treatment. That's all, right? Gallstone ileus. I mentioned to you about this is a complication of gallstone. Again, stone enter the intestine. Remember, that was the duodenum, also is a part of intestine, but specifically entity was that was bilioduodenal fistula. Here we are having biliointestinal fistula. So it will lead to mechanical bowel obstruction. Same is also causing obstruction of the intestine. Okay, so it is causing obstruction, and it can even go to ileus. Sometimes, most of the time, patient may not have much of the symptoms. not much symptoms. Okay, but one thing is very important. This is the classical gold medal question. Patient may not much of the problem because of ileus, but one thing is there, that patient with these patient will not be able to, if you do surgery in these patients, surgery what we do is cholecystectomy. You try to remove the gallbladder, although it's done very fast nowadays. But these patients, especially the elderly person, they may not be able to withstand surgical procedure. The question what is relevant to you is that patient having ileus, gallstone ileus, surgery should not be done. The surgeon should wait for the surgery. Wait for the surgery till the ileus is over. So friends, this is the key word to remember is biliary enteral fistula, and that can lead to obstruction and that can lead to ileus also. Okay, gallstone ileus. So we got stone coming from the gallbladder to the intestine. It may be between gallbladder and duodenum. This was the Bowet syndrome. And second is gallbladder and the transverse colon. Second one, which I told you, which can lead to, that's why I told you the patient has no symptom. Normally when we talk about ileus, it is more of a small intestine with the term ileus we use. But here this fistula form between the transverse colon and the gallbladder, but it can be in the small intestine also. But the second common site is transverse colon. Now we have one more entity, again a gold medal or rank number 1 getting is Wriggler's triad, not known to 99% students. What is this? It is small bowel obstruction. Oh, right. We discussed the previous one. Let us see what is happening. What are the additional finding we are getting it. One is obstruction. So it is a fistula formation between small intestine and gallbladder. Oh, so recall my words, go back. So we are getting gallbladder, fistula with the duodenum, fistula with the transverse colon, and now in regular triad they are talking about in the small intestine. That means the gallbladder can have connection with the duodenum, small intestine or transverse colon, anywhere it can break. The most common site is duodenum. So let's come to regular triad. Small bowel fistula formation, the stone has gone to small intestine and that will lead to obstruction. Number 2, something very interestingly, stone can be even outside the gallbladder, ectopic gallstone. It has gone out. Oh, it has a special meaning. Anyway, remember ectopic gallstone. And air in the bile duct, so-called pneumobilia. Air in the bile duct. So friends, number 1, small bowel obstruction in the triad of regular. Second is ectopic gallstone. This is the first keyword. Second keyword and third keyword is hemobilia, that is air in the bile duct. Let's learn more about hemobilia. Pneumobilia. It means air in the biliary tract. Why? Because what I told you, this is the gall bladder This is the small intestine, and the fistula is getting made between the gallbladder and the small intestine, and intestine has lot of air. This air, this air can enter the gallbladder. So it's the reverse flow of air going into gallbladder, what we call as pneumobilia. So air going from bowel into the biliary tract. Okay, so friends, we have the first one is small bowel obstruction because of gallstone going into the small intestine. Fistula is made air, so stone can come into intestine, air can go up, very simple. So air stone coming down will create obstruction, and air going into the gallbladder will create pneumobilia. And let's say once again, here is the gallbladder, here is the intestine, here is the stone. This stone has come here via the fistula. Let us say if fistula is made like this, fistula is a connection between the two, gallbladder and the intestine. It has come here and that lead to obstruction. But air has gone like this. So we are getting air. But what about the stone? We may have a stone like this, which has come, and from the fistula it has come out. From the fistula or any opening in the gallbladder wall has come out, but it could not enter the intestine. So you can find it is just hanging or just staying outside the gallbladder, so-called ectopic gallstones. So now you can understand why and how ectopic gallstone will be there, why air will be there, and why intestinal blockage will be there, and they together are known as regular triad. Okay, I hope you are clear about it. Now, regular triad is seen in 6 to 7 decades. That means it is seen in the elderly person. Although the gallstones are common in the age of 40-50 years of fat fertile female, but this is in the 6 and 7 decades. Affect more often in female. In fact, the gallstone disease as such is more common in female. So definitely we expect this finding to be more common in females. Lovely diagram, beautiful picture. I'm enlarging it. So we have a gallstone. I hope you can see it. Yeah, I have enlarged to the maximum. We are getting small bowel obstruction. You can see multiple levels, and you can see gas in the gallbladder area, so-called pneumobilia. All the three classical findings I have described have been shown into this lovely picture. Okay, pneumobilia, small bowel obstruction, and the gallstones. Point to be noted: gallbladder is here, and stone is in the intestine. Point to be noted. So now, how to treat a case of gallstones? First of all, in the PECA, they do try for medical therapy, but it is not a very successful. Okay, we can try to dissolve small gallstones, but that take about 6 to 12 months. And what we use ursodeoxycholic acid. That means you keep on giving ursodeoxycholic acid, and that can dissolve, but that may take about 6 to 12 months, long time. and recurrence rate is as high as 50%. But point to be noted, is done only for small gallstone, so not a very popular method of treatment. So only keyword you have to remember is ursodeoxycholic acid. Well, I have a question only for the student. Tell me in which other disease we have used this ursodeoxycholic acid. Quickly write down the answer in your copy. In which other disease we have used this ursodeoxycholic acid? Well, we have used in primary biliary cirrhosis, PBC is primary biliary cirrhosis. We also use in primary sclerosing cholangitis. Primary sclerosing cholangitis, I have taken a full lecture on these two topics. You can very well see this lecture to know more about the use of ursodeoxycholic acid. So the only keyword to remember is ursodeoxycholic acid, but not a very popular method, repeating second time. Well, when we use, what are the prerequisites? We use only for small, I told you less than 1 centimeter size. Gallbladder should be functioning, and it should be, patient should not have acute symptom. So we use only for the non-acute, or maybe perhaps incidental finding is the better answer for this. Now surgery. Of course, ultimate treatment is surgery beyond doubt. So let us see now what he is going to ask you in the exam. Right? Patient has some symptom. Okay. Then we can plan for surgery. Plan for surgery. What and how I'm going to discuss in a minute only. Especially those diabetic patient and pregnant, this is important. Right? If the patient is diabetic or pregnant, they need a special follow-up, even if there are no symptom. They are asymptomatic. Well, the patient is pregnant, ultrasound was done for pregnancy reason, and the stone was picked up. And remember, even diabetic patient has no symptom, but these two patients, we have to special close follow-up. There's a reason behind that. As far as diabetic patients are concerned, they can develop emphysematous cholecystitis. Patient may develop gas in the gallbladder. Pregnancy lady again can have other problem. About this I'll be discussing later on. Well, patient has a calcified or porcine gallbladder. They should be considered for cholecystectomy, remove the gallbladder. Even they may not have any symptom. Why? They are the one which can cause increased risk of cancer. When I discuss about the complication of gallbladder, one of them was carcinoma. Carcinoma cancer, gallbladder can develop in those patients who have a calcified or porcine gallbladder. Okay. So keyword to remember are diabetic, pregnancy, and the porcine gallbladder. 3 keywords you have to remember. These 3 patients have no symptom, but they need to be very careful follow-up. Ultimately, patient laparoscopic cholecystectomy is the treatment of choice if acute cholecystitis is there, and it should be done within 72 hours. This is the golden line to remember. Okay. But suppose the patient come later on, maybe after 5-7 days, after 72 hours, the patient should be first given conservative therapy, antibiotic, and 4 to 6 later surgery should be done. So golden line to remember, within 72 hours, do immediately. But if patient come after 72 hours, then you do 4 to 6 weeks later. Golden line to remember, surgery within first 72 hours, after 72 hours, give antibiotic and do surgery after 4 to 6 weeks. Now, what are the indication of cholecystectomy? Urgent acute cholecystitis. Point I told you within 72 hours. Emphysematous cholecystitis, which occur in diabetic patient, which I told you gas formation occurs in the gallbladder, and somehow very interesting, this is more common in males, diabetic males. Although cholecystitis and gallbladder stones are more in female, but emphysematous cholecystitis is more common in male diabetic. Empyema of the gallbladder is again indication of urgent cholecystectomy. Empyema means pus, and in this there was a gas in the gallbladder. Perforation, it has perforated, and any perforation is always a emergency surgery, any viscous perforation. And patient has a previous cholelithiasis and it was removed by the endoscope, but it has formed again, then again it should be done urgently. But out of these, don't forget these 4-1. These 4-1 are the urgent indication of surgery by cholecystectomy. Elective surgery, we can plan for biliary dyskinesia, where we are finding the bile bladder is not contracting properly, and even after meals also, you can see the gallbladder is distended gallbladder after meals. Chronic cholecystitis is there, and symptomatic cholelithiasis is there. Okay, in such cases we can plan. It is asymptomatic cholelithiasis. Okay, patient has no symptom, asymptomatic cholelithiasis, but stone is there. In such cases we are not in a hurry, we can plan, elective surgery can be done. Okay, well, acute cholecystitis means within 40, as I told you, within 72 hours is acute cholecystitis. So this was about gallstone. I hope you learned a lot about the gallstones. Mucocele, basic concept I discuss. So now my work become easy. What we have learned, we have a gallbladder, and epithelium of the gallbladder secrete mucus, and if gallbladder duct is blocked, excess of mucus can come and that make mucocele, the point we discussed in the basic concept. So mucocele result from prolonged obstruction of cystic duct, and that especially the gallstone, we have a gallstone, cystic duct, and the mucus is coming, and that make the mucocele. I don't think I need to talk again on these issues. So ultimately, lot of mucus is there, mucocele. But sometime uncommonly, it may be even clear transudate also, what we call as hydrops. But most of the time the word is mucocele because that contains mucus. So only one keyword so far is that duct is cystic duct get blocked, and that make the collection of mucus so called mucocele. That's all. What are the clinical features? Easily palpable, non-tender gallbladder. Point to be noted. It's non-tender. It means what? Murphy's sign will be negative. Okay. But it's a huge, easily palpable, and it can expand like a balloon. Huge. Right? So most of the time, the only finding will be no pain, no tenderness. The patient will come with a lump abdomen. He will see, I can feel a swelling in the right hypochondrium. So friend, the first keyword was collection of mucus. Second keyword is very enlarged and easily palpable. An easily palpable gallbladder. Second keyword to remember. No tenderness. Murphy's sign will be negative in these cases. Treatment is surgery because it is a big balloon, contain lot of mucus. It can get infected, empyema may be made. It's a big balloon, it can perforate any time. It's a very big balloon, it can twist, it can have gangrene. So all these are very dangerous. If you look into this, they all are very dangerous complications, whether it's empyema, whether perforation or gangrene. They're all, it itself is not it's a very benign condition, but it can land up in the severe problem, empyema, gangrene or perforation. So this one where we have to do urgent. Of course, it is elective surgery, but you cannot delay. You can't say, okay, we'll see after 1 year. No, get it operated as early as possible. Elective surgery, but urgent surgery. So friends, golden line to remember about gallstone, which I told you, a fat, fertile female of 40 years coming with right upper quadrant pain, which is referred to right shoulder, with positive Murphy's sign. This is gall bladder stone. This is gall bladder stone is there. Fat, fertile female of 40 years coming with right upper quadrant pain, and that pain is referred to the right shoulder. Positive Murphy's sign, which examiner will ask you when the abdomen was palpated, and we asked the patient to take a deep breath, and there was a inspiratory arrest. Inspiratory arrest. This is gall bladder stone with cholecystitis. Okay, thank you very much. God bless all of you.